Good morning, everyone, and welcome to this webinar. My name is Dr. Tom Madayag, and I am a faculty at the BSN program at Broward College. My experience in preparing nurses for the NCLEX has been a long time ago, and this presentation actually is part of a seminar, an 80-hour seminar that I usually do to prepare nurses for the NCLEX. I'm glad to help you with your NCLEX preparation, and I want to congratulate you for your graduation in the ASN program. And I hope that we will have some time together to be able to prepare you for the NCLEX. So let's go ahead and get started. The way in which this is done is that all sessions are recorded so that you can access them at the end of the presentation if you have a need to do so. And for those that do miss a particular session, that also is an opportunity for them to catch up. Now, we are meeting for 9 days in total, and we're going to be focusing on some important topics that appears in the NCLEX quite often. And so for the first presentation for today, we're going to have a case study on heart failure. And so this serves as a preparation for your NCLEX examination. Please feel free to stop me at any time to ask questions if you have a need to do so. Okay? All right. So imagine that you have an admission with all these symptoms: activity intolerance, maybe edema, jugular neck vein distension, and maybe shortness of breath. One of the things that you might think of is that this is cardiac and pulmonary related. And exactly is the reason why we need to review this particular topic in order to prepare us to identify some of the signs and symptoms as well as the nursing interventions for patients with heart failure. We begin with a definition of heart failure. What is heart failure? When we talk about heart failure, this is a syndrome. A syndrome means to say a collection of symptoms, and they're characterized by signs and symptoms of fluid overload and also of inadequate tissue perfusion. Now, as the term suggests, failure of the heart. This is the inability of the heart to pump sufficient blood to meet the needs of the tissues for oxygen and, of course, nutrients. So it used to be referred to as congestive heart failure, but research and evidence have shown that not all patients with heart failure usually end up with congestion, and thus the correct designation is now heart failure. Before we go to a discussion on heart failure, it's important to discuss some terms. And these terms are going to be very, very much important in understanding the physiologic changes that occurs when a patient has heart failure. And the first one is preload. Preload is also referred to as an end diastolic volume. And so I like to illustrate that by saying that anything that enters the heart at any time is what is known as a preload. So if this were the heart, let's say the right atrium and right ventricle, the volume of blood that goes into it is what is known as preload. All right, so you could have a right ventricular preload or a left ventricular preload. And preload, therefore, is going to be an important determinant of cardiac output. So when we talk about preload, we are talking about the amount of ventricular stretch at the end of diastole. So let's say that you have a, let's say, dehydration. What happens to your preload? Is your preload going to be increase, decrease, or unchanged?
Decrease.
Can you put in your chat, in the chat box, your answer? What happens to preload whenever you are dehydrated? It would be decrease. Very good. Now, let's say that you forgot to control the IV, and the IV of 500 cc's suddenly is infused to the patient within 10 minutes. What happens to preload? The preload is going to be increased. So at least now you understand the dynamics or the physiology of the volume that is going to enter the heart is a determinant of the ventricular stretch at the end of diastole. Now, cardiac output is determined by the influence of preload, myocardial contractility, and something that is also a physiological parameter called afterload. Afterload is also known as systemic vascular resistance. So let's say that this is the heart again, and it is going to eject its blood in a blood vessel that is this size, and compare that to ejecting it to a blood vessel this size, letter B. All right, which one is going to be easier to unload the volume that is collected in the ventricle? Would it be A or B? Okay, everybody's saying A, and that is correct. The reason is it is wider. It actually has lesser resistance against the volume that's going to get out. And that's exactly what we're talking about when we say afterload. Afterload is the pressure or the resistance against which the ventricles are going to encounter when they eject blood. So let me give you an example or questions. If a patient is given a drug that vasodilates, what happens to the afterload? If I give you a vasodilator, what happens to the afterload? Is it going to be increase, decrease, or normal? No. Your afterload would be decreased if you're vasodilated, okay? Because you have lesser resistance. But let's say now that if you have a drug that is given to a patient and they're vasoconstricted, their afterload is going to be increased. Okay, so that is the reason why whenever you are having, let's say, a drug that vasodilates, what's going to happen is you're going to have a decrease in blood pressure. You will have a decrease in your afterload. Okay, so decreasing the afterload actually is going to diminish the work of the heart. And this is why this is a very important component of this discussion, is to understand what preload and afterload is. Okay, so going back to this slide now, the slide shows you cardiac output. Cardiac output is the volume that is pumped from the heart in 1 minute. It is a product of the heart rate and the stroke volume. And normally our cardiac output is around 4 to 8 liters per minute. That's the normal cardiac output. And of course, the cardiac output is going to be very important in this particular discussion because of the fact that in these kinds or different kinds of heart failure, the cardiac output is going to be either increase or decrease. All right, so let's go on now to another term before we go to a discussion on heart failure, and that term is ejection fraction. What is a ejection fraction? Well, when we talk about ejection fraction, it is the amount of blood that your heart pumps each time it beats. So it's measured as a percentage of the total amount of blood in your heart that is pumped out with each heartbeat. All right. So ejection fraction is very, very important because without the understanding of ejection fraction, we will not be able to understand heart failure. So let's say that the volume of blood in the heart is 100 cc's. Let's say that this is in the ventricles. When the ventricles contract, you all think that 100 cc's is ejected, and that is actually incorrect. All right? Not all the blood that is going to be contained in the ventricles at the end of diastole is going to be ejected. Only part of it will be ejected. Actually, a normal ejection fraction would be around 55% or higher. So let's say that this ventricle is contracted, and what comes out is 50 cc's. The ejection fraction, therefore, is 50%. This is lower than normal. Okay? So in going back to the slide, again, ejection fraction is the percent of blood that is pumped out with each heartbeat. The normal ejection fraction is around 55 to 70%. Anytime your ejection fraction is below 40%, it means that your heart isn't pumping enough blood and may be failing. So this is going to be one of the diagnostic markers for a patient having a heart failure. So we have talked about different terminologies. We have preload, afterload, and we also talk about ejection fraction, which are very, very important concepts in order to understand heart failure. Okay, so with that in mind, now we are going to talk about the pathophysiology of heart failure. Heart failure results from a variety of cardiovascular conditions, including, for example, chronic hypertension, coronary artery disease, and valvular disease. And as heart failure develops, the body activates neurohormonal compensatory mechanisms. And so what are some of these neurohormonal compensatory mechanisms? Well, for one, there's going to be the activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system. So I don't know if you recall what the renin-angiotensin-aldosterone system is. And this is going to be something that is a compensatory mechanism of the body. Now, normally, when there is a decrease in blood pressure in the body, it is going to be sensed by the JG cells, or the juxtaglomerular apparatus of the kidney. And what it does is it's going to release a substance called renin. Now, the liver, on the other hand, is going to release a substance called angiotensin. And angiotensin is going to be converted into another substance called angiotensin II. And this conversion is made possible by an enzyme called angiotensin converting enzyme. Now, this angiotensin 2 is a very potent vasoconstrictor. So if we constrict, what's going to happen to the blood pressure? You're going to increase the blood pressure. The release of angiotensin II also stimulates the release of another substance, and this substance is going to be aldosterone. And aldosterone has two functions. It reabsorbs sodium. When you reabsorb sodium, what happens to blood pressure? When you reabsorb sodium, what happens to blood pressure? Increase, very good. But it also eliminates potassium. All right, so whenever we have, therefore, a insult of the cardiovascular system, what's going to happen is you're going to have the activation of neurohormonal compensatory mechanisms, which includes or involves your renin, angiotensin, aldosterone system. Now, this is going to be very important later on the treatment and the pharmacological management of heart failure. We're going to be using some of these mechanisms in order to stop the progression of heart failure. So that's exactly what happens right over here when we said that whenever we have heart failure, there's going to be activation of the renin-angiotensin aldosterone system and the sympathetic nervous system. What does the sympathetic nervous system do whenever there is an insult or a decrease in the functioning of the cardiovascular system? Well, adrenaline or epinephrine is going to be released from the adrenal glands. And adrenaline has several effects. One is going to stimulate alpha receptors. Alpha receptors are those found in blood vessels. And this will cause vasoconstriction. It also is going to affect beta receptors. Where are these beta receptors found? There are two types basically of beta receptors. How many heart do we have? One heart. How many lungs do we have? Two lungs. So we call this beta 1 and beta 2. Okay. What does adrenaline do to the heart? It increases the heart rate. What does adrenaline do to the lungs? It causes bronchodilation. Okay? So this is exactly what happens with the sympathetic nervous system. So with an initial myocardial insult, what's going to happen is the body responds with the activation of either the renin-angiotensin-aldosterone system and the sympathetic nervous system. So we had already said that one of the things that's going to happen as a result of the increase in the sympathetic nervous system is going to be your actions on the heart as well as in the lungs. So when we talk about positive chronotropy and inotropy, what does that mean? That means to say chronotropy is like chronology. This refers to increase in heart rate. So give me a positive chronotropic agent. Anybody? What is a drug that increases heart rate? That means to say it is a positive chronotropic agent. Give me Levophed. Okay, very good. What else? Epinephrine. Okay, epinephrine is going to be one that increases the heart rate. That is a chronotropic agent. Atropine is also a chronotropic agent. So when we say chronotropic agent, we either could mean a positive chronotropic agent that increases the heart rate, or a negative chronotropic agent that decreases heart rate. So give me a negative chronotropic agent. Give me an example of a negative chronotropic agent. Something that slows down the heart rate. Okay, metoprolol. Nazir said metoprolol, which is a beta blocker. Digitalis is also going to be a negative chronotropic agent. Okay. Now, when we say inotropy, on the other hand, what does inotropy mean? Inotropy means to say force of cardiac contraction. Force of cardiac contraction. Now, when we say positive inotropy, that means to say we increase the force of contraction. Negative inotropy, that means to say that we decrease the force of cardiac contraction. Give me a positive inotropic agent. What is a positive inotropic agent? No, inotropy means it increases the force of cardiac contraction. Atropine increases the heart rate, but not the force of cardiac contraction. Digitalis, very good. Digitalis is a positive inotropic agent. Also, you're going to have epinephrine as a positive inotropic agent. Okay, give me a negative inotropic agent. What is a negative inotropic agent? It decreases the force of cardiac contraction. A beta blocker, a calcium channel blocker, decreases the force of cardiac contraction. Very good. Okay, so now you already understood those terms. Whenever we have an activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system, particularly the sympathetic nervous system, it leads to a positive chronotropy and inotropy. This is going to be a compensatory mechanism for the failure of the heart. And in addition to that, what happens when you have an increase in heart rate, unfortunately, you also have an increase in workload of the heart and also tachycardias as well as arrhythmias. So whenever you have cardiac insult with the activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system, it leads to a positive chronotropic and inotropic effects. But unfortunately, it increases the workload of the heart. And then, of course, we have what's going to happen is that when you have destruction of heart muscle, you're going to have myocardial remodeling. And what exactly is remodeling? Remodeling is the change of the shape and structure of the heart. So an example of that would be an enlargement of the heart, and that is known as hypertrophy or fibrosis or scar formation, as well as apoptosis or the death of cardiac tissue. So those are some of the things that are going to occur. And then the other thing is that as a result of the renin-angiotensin-aldosterone system, you're going to have sodium and water retention. So when you have sodium and water retention, it increases your ventricular volume load, and therefore the workload of the heart is going to be increased, and it leads into congestion. Now, all these are going to activate another system, and that system is the NP system, and the NP stands for natriuretic peptide. These are things that are going to be released by either the atrium or the ventricles, which are going to be a manifestation of overstretching of the atria or ventricles. So that's exactly the pathophysiology of heart failure. And now I'm going to simplify that a little bit by illustrating it to you. Okay. So suppose that a patient has had a myocardial infarction. So there's a cardiac insult. And what happens then when you have a cardiac insult is maybe part of this heart is going to die. So that's what infarction means, is part of the heart is going to die. So what happens, therefore, to your cardiac output? Your cardiac output is going to be diminished, and therefore it leads to compensatory mechanisms, and these compensatory mechanisms could either be the sympathetic nervous system. You remember epinephrine is going to be released, and then your renin-angiotensin-aldosterone system is going to be released. And this is going to cause an increase in sodium reabsorption, a decrease in potassium because it's excreted, and of course, what else are the other functions? The angiotensinogen will be, angiotensin 2 will cause vasoconstriction. So all these things are going to precipitate the things that we had illustrated over here, which causes all the effects that we're going to be discussing as the signs and symptoms of heart failure. All right, so whenever we have heart failure, there's actually two ways in which the heart can fail. And one is what's called a systolic heart failure. And the other one is what is known as diastolic heart failure. Now, when we say systolic heart failure, the heart cannot pump enough blood. And when we say diastolic heart failure, the heart cannot fill enough. Okay, so we have two kinds of heart failure. We have what's known as systolic heart failure, wherein the heart cannot pump hard enough, and the diastolic heart failure, where the heart cannot fill enough. So this is one of the most common classifications of heart failure. But actually, heart failure could be classified on three ways. One is based on the side of the heart that's affected, based on whether or not it's acute or chronic, and based on ejection fraction. So let's talk about these different kinds of heart failure And let's go first to the side of the heart that is going to be affected. So you could either have a left-sided heart failure or a right-sided heart failure. So let me illustrate that. If this is the right side of the heart, right atrium and the right ventricle, pulmonary artery, the lungs, left atrium, left ventricle, and aorta. Okay, so the reason why I made this illustration is because I wanted to illustrate to you why there's a difference between a left-sided heart failure as right-sided heart failure. Is it same as preserved ejection fraction versus reduced? Yeah, Patrick, we'll go to the ejection fraction in a little bit, okay? All right, so as far as left-sided heart failure is concerned, the left side is going to fail. So the left ventricle is now going to fail its role in moving forward blood to all parts of the body. So what's going to happen if you have failure of the left ventricle, this is going to happen. The fluid cannot move forward readily from the left atrium to the left ventricle, and it therefore causes congestion in the lungs. So the traffic is going to be in the lungs. Thus, anytime you have left-sided heart failure, pulmonary congestion occurs when the left ventricle cannot effectively pump blood out of the ventricle into the aorta and the systemic circulation. So this is going to force fluid from the pulmonary capillaries into the pulmonary tissues and the alveoli, and therefore will now interrupt with gas exchange. So in left-sided heart failure, you're always going to have respiratory symptoms, okay? So it's almost like when you have you're on I-95, and of course, there's going to be a traffic over here or an accident over here. Where would the congestion be? The congestion will be in this side, not in this side, okay? So in here, as illustrated over here, if the congestion is in the left ventricle, therefore the backup of traffic will be in the lungs. And thus, anytime you have left-sided heart failure, you will always have pulmonary congestion and impairment of gas exchange. Why would there be an impairment of gas exchange? Again, if the lungs is going to be, let's say, if this is the alveoli, and there's a lot of fluid over here, oxygen cannot readily diffuse into the capillaries, and carbon dioxide cannot diffuse into the alveoli to be exhaled. So that's why we have an impairment in gas exchange. All right, so let's take a look now at right-sided congestive heart failure. So if this is the right atrium and this is the right ventricle, and this is the pulmonary arteries and the lungs, left atrium and the left ventricle. The problem in right-sided heart failure is this is going to be incompetent in moving blood forward. Thus, where would congestion be? Congestion will be in the venous circulation. So venous circulation is going to be reflected into the liver, the spleen, the GI tract. And so congestion is going to occur in the periphery. So you're going to have peripheral edema, enlargement of the liver, which is known as hepatomegaly. enlargement of the spleen, which is called splenomegaly, and congestion in the GI tract would be manifested as ascites. Okay, so those are the symptoms that are going to accompany right-sided heart failure. There's going to be congestion in the peripheral tissues, and it leads to venous congestion. Okay, so that's the classification of heart failure based on the side of the heart that is going to be affected, either the left side or the right side of the heart. Now, another type of heart failure is going to be your systolic heart failure or your diastolic heart failure. Now, what is systolic or systole? Systole is the pumping or the squeezing of the heart. And in heart failure involving systolic heart failure, there's an inability of the heart to contract enough to provide blood flow forward. So when this happens, it results in decreased blood volume that's going to be ejected from the ventricle. And this is a result of the heart muscle losing its ability to contract. This is going to be known as your systolic dysfunction. What happens is that in this blood, your ejection fraction is going to be decreased. That is systolic heart failure. In diastolic heart failure, the problem is not in the contraction. The problem is in filling the heart, the inability of the left ventricle to relax normally, resulting in fluid backing up. So let me just illustrate this too. Let's say that you have a heart that is going to be a left ventricle that's going to be thin like this, compared now to a left ventricle that's going to be having thick walls. Okay. Which of these two will contain more blood, A or B? Which has more ability to contain greater volume? Is it letter A or letter B? Okay, very good. However, so in this particular instance, which one is going to have a diminished filling? Letter B is going to have a diminished filling. And that's exactly what happens when you have diastolic failure. There is going to be a failure when the heart is not able to rest between heartbeats. Normally, the heart is going to beat normally or relax normally, but in this particular instance, they might not. The reason is that they might be stiff, or maybe this is hypertrophy, and therefore there's going to be a decrease in the filling ability. So in letter A, because the balloon is so distended, it loses its elasticity. It can no longer pump out, and therefore it results in systolic heart failure. So systolic heart failure, again, is going to be a problem with pumping because of decreased contractility, and therefore there's a decreased blood ejected from the ventricle. So what we're talking about here is that there's a decrease in ejection fraction. In diastolic heart failure, there's not a problem with ejection fraction. There's going to be, in fact, a normal ejection fraction, and the problem is in the filling. There's a filling problem. The contractility is not affected. And the reason why there might be a filling problem is that the cardiac muscles are stiff, And over here, the ejection fraction is normal. And the preload is normal or decrease. So these are one of the classifications, or one classification of your heart failure. So we've talked about on the side that's affected and based on the ejection fraction. So heart failure with reduced ejection fraction is your systolic heart failure. And of course, your heart failure with preserved ejection fraction, this is going to be your diastolic heart failure. We're not going to talk about this mid-range because that's the one that is in the middle. That's not going to be something that will be relevant in the NCLEX. Okay, so therefore, your heart failure could either be left-sided or right-sided, or it could be either a systolic heart failure or a diastolic heart failure. Now, whenever there is heart failure, there's going to be compensatory mechanisms that are going to be activated. And this includes, of course, your sympathetic nervous system activation that we have talked about. And then, of course, it could also be uncompensated, where therefore there's going to be deterioration of the condition and the patient develops symptoms such as lung congestion or peripheral edema. Okay, so I think that that is enough to introduce what heart failure is. I wanted to find out from you if you have any questions, first of all, before we move forward to the diagnosis of heart failure and then to our case study. Let's see if you have any questions. Okay, if not, then let's go ahead and have our first poll. Okay, so let's take a look at the question. Which patient statement is not accurate on left ventricular systolic dysfunction? All right, signs include cough, difficulty breathing, and weight gain. This is going to be a symptom, right, in left ventricular systolic dysfunction. You're going to have congestion in the lungs. It is important to monitor daily weights, fluid, and salt intake. Well, this is a, what do you call that? Description of right-sided heart failure and not left ventricular systolic dysfunction. And left-sided heart failure can lead to right-sided heart failure if left untreated. That's correct. This heart failure can cause peripheral edema from venous congestion. That is incorrect, because this is going to be a manifestation of right-sided heart failure. Okay, so option D is the answer. This more describes right-sided heart failure, not left ventricular systolic dysfunction. So when you have systolic dysfunction, the left side of the heart will be unable to contract efficiently, which causes the blood to back up into the lungs, leading to pulmonary edema. Okay, so the correct answers are letter A, letter B, and letter C. Distinction is based on ventricular ejection fraction. Remember now that in systolic failure, there's going to be a decrease in your ejection fraction. And in your diastolic dysfunction, this is going to be either a normal or even sometimes increased ejection fraction. Letter D, in diastolic dysfunction, the EF decreases. That is incorrect because that actually could remain normal or even increase because of the increase in cardiac muscle. Okay? All right, next. Okay, so let's see, let's review this. The most common causes of left-sided heart failure include which physiologic responses? It would be hypertension and acute myocardial infarction. So let me explain this because a lot of you answered letter chronic pulmonary diseases as well as impairment in renal blood flow and tricuspid dysfunction, which are actually incorrect. Okay, so let's begin with right-sided heart failure. If this is the right atrium and the right ventricle and the pulmonary artery. All right, so what are some of the possible conditions that would create problems on the right side of the heart? Now, if we have a narrowing of the tricuspid valve, and narrowing of the tricuspid valve is also known as stenosis, what is going to happen? You're going to have congestion in this area because the blood that is in the right atrium cannot readily go through into the right ventricles. So a tricuspid valve dysfunction would be a common reason why you would have a right-sided heart failure. The more common one, however, could be pulmonary valve dysfunction right over here. So this is the pulmonary valve or pulmonic valve. If you have a pulmonic valve stenosis, again, blood cannot readily move forward into the pulmonary artery. And therefore, this would be a cause of right-sided heart failure. Now, whenever you have pulmonary disease, you have a condition known as pulmonary hypertension. And pulmonary hypertension is going to cause narrowing of pulmonary blood vessels. So these pulmonary arteries would be very, very narrow. If they're very narrow, again, they're going to cause backing up of blood in the right side of the heart. And therefore, it would cause right-sided heart failure. Now, let's go to left-sided heart failure. What are some of the causes of left-sided heart failure? So again, this is the left atrium, left ventricle, and this is the mitral valve. So if we have narrowing of the mitral valve, that is one, same thing as we had talked about before. And of course, if we have hypertension, and essential hypertension is a situation wherein there's going to be an increase in the afterload. And therefore, this would also cause left ventricular dysfunction or left-sided heart failure. And lastly, if there's going to be loss of the ability of this heart to contract because of myocardial infarction, this is going to cause left-sided heart failure. Okay, so that is the reason why letter D and letter E are the correct answers in this question. Okay, let's go to another question. Okay, so the question says left-sided systolic dysfunction. Okay, so in systolic dysfunction, we know that there's going to be a decrease in your ejection fraction. So letter A is going to be correct. And because it's left-sided, we're going to have respiratory symptoms. So letter C is going to be correct as well. Now, letter B is a finding that would be expected in left-sided diastolic dysfunction, not systolic dysfunction, because the issue is with the ability of the ventricle to fill properly. Therefore, a patient usually has a normal ejection fraction in a diastolic dysfunction. Remember, a normal ejection fraction is going to be normal above 60% in a healthy heart. So therefore, the correct answers are letter A and letter C. Okay, let's go to another question. Okay, so remember the answer is true. Patients with left-sided diastolic dysfunction normally have a normal ejection fraction. However, patients with left-sided systolic, if it's systolic dysfunction, they usually do not because the heart is unable to contract efficiently rather than fill properly as with diastolic dysfunction. Okay, so the correct answer is true. All right, let me see if you have any questions. I'm going to pause to see if you have any questions. The previous question says only one. Oh, I'm sorry. It should have been like select all that apply because which are expected findings. I'm sorry. Which one would be more correct? Well, letter A would be more correct. Okay, because the ejection fraction is going to be diminished in systolic dysfunction. You're welcome. Okay. All right, let's see if you have any more questions before we proceed to the etiology as well as the causes of heart failure. All right, the etiology of heart failure it can actually affect both women and men, although the mortality is higher in women for some reason or another. There are also racial differences. Death rates are higher in African American than non-Hispanic whites. And the older you are, the more likelihood of you getting heart failure. Actually, heart failure is a disease primarily of older adults. It is also the leading cause of hospitalizations in older people. Now, the risk factors that are associated with heart failure are similar to the risk factors that are going to be associated with coronary artery disease, and they include hypertension, diabetes, obesity, blood clot, stroke, family history, as well as toxic medications, which could cause, of course, destruction of myocardial tissue. Now, here are some of the major causes of heart failure. Coronary artery disease or atherosclerosis is going to be a primary cause of heart failure. And of course, ischemia, which is a decrease in the oxygenation of heart cells, which is going to, of course, precipitate the formation of or accumulation of acidosis from lactic acid increases. Cardiomyopathy. This is going to be a major cause of heart failure, as well as pulmonary hypertension and valvular heart disease, which we discussed earlier. Okay, for the NCLEX, if the question is select all that apply, I'd like for you to be very, very cautious and careful because there's a penalty for answering more than the correct responses. Okay, so it's right minus wrong scoring. And so you're better off selecting only a few rather than too much. All right. So the answers to this question is actually options A, C, and E. These patients are going to be more at risk for heart failure. Remember that MI as well as valvular problems, which is letter C, and hypertension are the most common causes of heart failure. Okay, so let's take a look at the conditions that are associated with diastolic failure. Well, the ones that causes a diastolic failure are those conditions that impede the expansion of the ventricles. So therefore, pericarditis would be one. And also those that increase the wall thickness and reducing the chamber size of the ventricles. So that would be myocardial hypertrophy. And those that delay the relaxation of the heart, like, for example, in ischemic heart disease. Letter D, volume overload and valvular stenosis are going to be related more to systolic failure. There's not going to be an efficient ejection of blood, and therefore, this is going to be more on systolic heart failure. Okay, which we've reached the 1 hour mark, and what I'd like to do is to have a 5 minute break, and then we come back and talk about clinical manifestations as well as management of heart failure. So let's take 5 minutes.
Battery 90%. After Q. iPad 10. Find a way to make you feel well. Can you feel all the windows inside this room? So I wanna touch you, baby. I wanna feel you too. I wanna see the sunrise when it sits just me and you. I need it up. I wanna run. Let's make love tonight. From that still no. From that still no. Baby, I'm walking like this. From that still no. From that still no. I would have some Gucci when I'm like booty.
What's the
Head down, cross town, living like a rock star. Spend a lot of money on my brand new guitar. Baby's got a habit, diamond rings and Fendi sports bra. Riding down Rodeo in my Maserati sports car. Stressed out through all that. I'm like a model, so I keep on back. Wish I could hold on to the old town. I wanna ride, and I can't no more.
Need nobody, I just need your body. Nothing but sheets in between us, ain't no getting up early. You know I'm always on the night shift, and we can stay these nights alone. Yeah, you don't need no explanation, 'cause baby, all the bars at home. I ain't gotta go to work, 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 but I gotta put in work, 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 work. I ain't gotta go to work, 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 work. Let your body do the work, 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 work. Get work, work.
Okay, I hope you're all back. Let's go ahead and continue with our discussion on heart failure. And this time we're going to talk about clinical manifestations. So let's go to the manifestations of right-sided heart failure. So when we have right-sided heart failure, we're going to have enlargement of the liver. Why is that? Because it results from the backing up of blood in the venous circulation. So the venous engorgement is going to cause the hepatomegaly. The other thing is that you're going to have GI symptoms of venous congestion. And what are some of the GI symptoms of venous congestion? Well, this would result obviously in the accumulation of fluid in the peritoneal space, and therefore this is going to increase more pressure on the stomach. And when it does that, it would cause GI distress. loss of appetite actually could result from venous engorgement and stasis within the abdominal organs. So these are the most common signs and symptoms of right-sided heart failure. Now, as far as left-sided heart failure is concerned, the manifestations are going to be centered or focused on the lungs. So dyspnea or shortness of breath may even be precipitated by very minimal activity. So the patient will have activity intolerance. There's going to be shortness of breath as well as cough. The cough often associated with left ventricular failure is going to be initially be dry and then non-productive. That's initially. And of course, you will be able to auscultate crackles, and it worsens. As it worsens, you're going to be able to hear, of course, crackles all over the lung fields. This would result in low oxygen saturation levels because of the increase in pulmonary pressures. So that's the comparison of the clinical manifestations of right-sided versus left-sided heart failure. Now, there are some authors that say you can remember right-sided heart failure signs and symptoms by remembering the acronym AWHEAD, and AWHEAD stands for anorexia and nausea, W weight gain, hepatomegaly, edema, ascites, and distended neck veins. For left-sided heart failure, you can remember it by the acronym DO-CHAP. Do, dyspnea, orthopnea, cough, hemoptysis, adventitious breath sounds, and pulmonary congestion. Okay, so it might be helpful to some of you in order for you to remember those. All right, next question. Okay, which questions will the nurse ask to confirm heart failure? Do you easily get tired? Well, this is going to be a classic one, particularly as a manifestation of left-sided heart failure, because of the decrease in their activity tolerance. Usually, these individuals are going to be will manifest activity intolerance. Swelling is going to be a manifestation of right-sided heart failure. Letter C is incorrect because usually when you have heart failure, the appetite is going to be diminished as a result of congestion in the GI tract. And then, of course, are you feeling depressed? Individuals who are going to have heart failure because of the activity intolerance as well as the general signs and symptoms usually will result in feelings of depression, and therefore that's also a manifestation. And letter E, do you get up often during the night to urinate? Nocturia is a sign of heart failure. And the reason for that is that it's the following. So let's say that there's going to be venous congestion. So the veins over here are going to be congested. Now, what happens when the person sleeps is that your cardiac demand is going to be decreased. And therefore, what happens is some of this fluid that's going to be in the interstitial tissues are now going to be reabsorbed back into general circulation. And when they're reabsorbed to general circulation, what's going to happen is it's going to increase blood volume and therefore increase diuresis. And that's also the reason why patients usually who have particularly left-sided heart failure will usually have attacks of pulmonary edema during the early morning or during the night because of this problem. Okay, so let me just explain that further. Now, when you have venous congestion, so your veins are congested, what happens to the walls of the vein? Do the vein walls become thicker or thinner? A or B? If there's congestion. Thinner. Okay. They become thinner because you're stretching them out. Now, when they become thinner, the walls then, which are usually semi-permeable, will now allow for albumin to go out. So albumin is going to be able to escape because now these are thinner. Okay. Albumin will, what do you call that? Draw or invite fluid to follow it. And that is why you have edema. Okay. Now, during the night, when the heart's demands are going to be decreased, what's going to happen is that this albumin starts going back into circulation. And therefore, water accompanies it. And now you're going to have greater renal perfusion, which causes the person to urinate during the night. So that is the reason why your nocturia is going to be a symptom of heart failure. Okay? All right, let's move forward and find out about what are the ways in which we can diagnose the presence of heart failure. Well, there are several diagnostic measures that we can do in order to detect the presence of heart failure. ECG for one. The reason why ECG is important because we all know that cardiac abnormalities may be the precipitating factor for the development of heart failure. In addition, arrhythmias can also contribute to the development of heart failure. An example of that would be atrial fibrillation. Actually, this is going to be one of the most common causes of heart failure. Chest X-ray is going to be very important in order to show whether or not there is enlargement of the heart, or maybe there's going to be congestion in the pulmonary vasculature. So these are going to be very helpful. Your sonograms, your echocardiography, your Doppler, and transesophageal echocardiography, these are also going to be very important because they could also, in addition to revealing anatomical abnormalities, will also be able to show you the ejection fraction. Stress testing as well as PET and cardiac catheterizations are going to be useful as well. Now, on the right side of the slide, there are other things that this is drug levels, not frog levels, I'm sorry. These are other things that could be done in order to help diagnose the presence and complications that might be associated with your heart failure. Now, the important blood test, though, is going to be your natriuretic peptides. And again, your natriuretic peptides, what are those? Well, these are going to be substances, they're hormones actually, that are going to be released with overdistension. So if your atria is overdistended, what's going to happen is the heart is going to release a hormone, and this hormone is what is known as an atrial natriuretic peptide. Now, if the ventricles are actually going to be distended, another type of natriuretic peptide is going to be released. And this is what's called the B-type natriuretic peptide, or BNP. The B stands for brain natriuretic peptide. Again, this is a hormone that is produced by the heart whenever there is going to be overdistension. And another one of those is going to be your N-terminal proBNP. This is also released in changes in pressure inside the heart. So if that is the case, therefore, it would be very helpful then to know that if there is an increase in BNP, there's going to be a manifestation of ventricular overdistension. Thus, this is going to be the hallmark for the diagnosis of heart failure, an increase in BNP, because this is more on the ventricles, okay? You could have an increase of this one and this one, but the B-type BNP, the B-type natriuretic peptide, is the biomarker that is going to be the hallmark to measure if there is excessive pressure in the heart due to heart failure. So usually if it is less than 100, it is going to be normal. So there's no heart failure. And then, of course, if there's going to be an increase over 100, then that means to say that you would have the presence of heart failure. And the higher the number is, the more severe the heart failure is going to be. Okay? So this is the hallmark that we are going to measure to see whether or not there is a presence of heart failure. Okay, so let's see. Is echocardiography going to be very useful in diagnosing heart failure? And the answer to that is yes, because it would provide us with the evidence of ejection fraction. BNP blood test, we just talked about that. This actually is going to be elevated or over 100 in the presence of heart failure. Nuclear stress test could determine whether or not there is a presence of a abnormality in the heart, like, for example, myocardial infarction or ischemia, which could be the causative factors for heart failure. And letter D, Holter monitoring is a procedure that actually is going to detect the presence of arrhythmias. So the patient wears this device over a 24 or 48-hour period. And the major reason why Holter monitoring is going to be used is to determine whether or not there's presence of arrhythmias. So obviously, that's not going to be related directly to heart failure, and thus the correct answer is going to be Holter monitoring. This is not used to diagnose heart failure. Now, in your exam in NCLEX, there might be statements such as a patient has a New York heart failure of 3 or 4 or so on and so forth. These are some of the ways in which heart failure is graded by different organizations. And there are 2 organizations that actually have published and is widely used as far as the staging of heart failure. The first one is going to be your New York Heart Association, and your New York Heart Association classification is going to be one that measures the functional ability of the patient. So heart failure stage 1 is going to be that there's no limitation, but in patients with stage 4, there's going to be severe limitations. So I just wanted to share this with you because you might be thinking that this is going to be something important to remember. Well, I just wanted you to be aware that classifications, the higher the number is, the more severe the heart failure is. And the other classification that is offered is by the American College of Cardiology. And this is going to be the American College of Cardiology. They stage it to stage A, B, C, and D. Again, the further it is, the more advanced the heart failure is. So that's all I wanted you to be aware of in relationship to the classifications of heart failure based on its severity. Let's focus, however, on the pharmacologic treatment of patients with heart failure. And so let's take a look at the management of heart failure to relieve symptoms, to improve their functional state, as well as the quality of life, and sometimes to extend their survival. So let's begin with the first drug, and they are your angiotensin converting enzyme inhibitors. So these are your ACE inhibitors, are those drugs that ends with the suffix pril. So if you take a look at this captopril, lisinopril, enalapril, ramipril, perindopril, all these medications are ACE inhibitors. So if you remember the renin-angiotensin-aldosterone system, so there's renin that was released, and then angiotensin 1, and was converted to angiotensin 2 by an enzyme called ACE. So these are the medications that are going to stop this one, okay? So you're not going to have angiotensin 2. If you're not going to have angiotensin 2, then you will not have vasoconstriction. And therefore, you will not have the release of aldosterone as well. Okay, so these are ACE inhibitors. They slow down the progression of heart failure. They improve the exercise tolerance of the patient. And they also are going to promote vasodilation. And therefore, it's going to be very useful for these patients. Now, usually, because the ACE, the enzyme, is located in the lungs, one of the complications or side effects of patients who receive ACE inhibitors is a non-productive cough. So that's the one thing that I wanted you to remember. This non-productive cough usually is going to it is not a manifestation of something serious. It is something that usually is going to be bothersome. In some patients, it's going to resolve, but in other patients, it will continue. And if it does continue and become bothersome to the patient, then we would switch them to the next type of medication, which are your angiotensin II receptor blockers. Okay, so that's the ACE inhibitors. They are the ones that end with pril. So let's take a look at the angiotensin II receptor blockers. These are the medications that end with sartan. So if you see over here, losartan, valsartan, candesartan, all these medications are angiotensin II receptor blockers. So in looking at RAS again, you remember in RAS, we have renin, angiotensin I, and it's converted to angiotensin II. Who converts it? ACE. So these are the medications that are pril. This is the medications that are sartan. Okay, so if you block angiotensin II, what happens? You will have vasodilation. Vasodilation then will make it a lot easier for the heart to pump against it. Nazir said patient may sometimes not take their medications due to the cough. Correct, and that is the reason why it's important to teach these individuals that when they are on ACE inhibitors, if they're bothered by the cough, usually it disappears after a while, but in some patients it persists, and so the doctor or the provider would need to change it to an angiotensin II receptor blocker, because they're going to actually end in the same result. Okay? Good point, Nazir. Thank you. All right. So your angiotensin II receptor blockers, which are your losartan, valsartan, candesartan, are going to be effective in the management of these patients. Now, the one thing that I'd like for you to remember is these medications are going to cause potentially hyperkalemia. So let's discuss why is it that your angiotensin converting enzyme inhibitors as well as your angiotensin receptor blockers are going to cause hyperkalemia. This is a common question in the NCLEX. So remember that with the formation of angiotensin II, it causes vasoconstriction, right? But it also is going to activate aldosterone. What were the two functions of aldosterone? The first function was, remember, reabsorb sodium. What was the other one? What was the other one? Eliminates potassium. So now what you're going to do is to block this angiotensin II. You're therefore blocking this, so you're going to have elimination of sodium and your reabsorption of potassium. That is the reason why you have hyperkalemia. So it always is a common question in NCLEX about this hyperkalemia for ACE inhibitors and your ARBs, angiotensin receptor blockers. Remember that you should not teach these patients to increase their potassium intake because hyperkalemia is a side effect of both drugs. All right? Okay, so the other ways in which we could actually manage patients with heart failure is to use beta blockers. And this is going to block the effects of the sympathetic nervous system. So you remember that the sympathetic nervous system is activated along with the renin-angiotensin-aldosterone system. So if you give a beta blocker, you are going to block the effects of your adrenergic or sympathetic stimulation. Okay. So for those of you who were lost with that, whenever we have stress or whenever we have a physiologic stressor in the body, the sympathetic nervous system responds. And how does the sympathetic nervous system respond? It releases a substance called epinephrine or adrenaline. And epinephrine is going to be looking for receptors or doors. So there are several doors to welcome epinephrine, and those doors are called alpha receptors. And the other one is called beta receptors. So alpha receptors are found mostly in the vasculature or blood vessels. And so vasculature. So they constrict. Now, beta receptors are of two kinds, beta 1 and beta 2. And beta 1 is abundant where? Where is beta 1 receptors abundant? In the heart. Remember, we have one heart, and the beta 2 receptors are in the lungs. Okay, so in the heart, they increase inotropy, or the force of contraction, and also increase chronotropy, which is going to be heart rate. And the lungs, it causes bronchodilation. Okay, so if you give, therefore, beta blockers, they are going to reduce the inflammation, the stimulation of the sympathetic nervous system. And so unless contraindicated or not tolerated, a beta blocker is usually started for every heart failure patient with an ejection fraction of less than 40% because it reduces the mortality based on controlled trials or research. Okay, so beta blockers are going to be drugs that end with OLO. So these are the medications that end with Pril. These are the medications that end with Sartan. And these are the medications that ends with OLO. Okay, so examples of those would be your carvedilol, bisoprolol, metoprolol. All those medications are beta blockers. And one of the things that you're going to make sure that you understand that in addition to the decrease in blood pressure, or your beta blockers can cause bradycardia. And of course, in addition to causing a low blood pressure. Other medications would be your digoxin. Why is digoxin going to be important? Because it improves your contraction and therefore the inotropic effect. And we all know that digoxin is going to be one that slows down the heart rate as well as increase the force of cardiac contraction. And lastly, the other drug that is going to be useful is ivabradine. This is a heart rate lowering agent, and this is going to act by selectively inhibiting the cardiac pacemakers, and therefore this is going to cause the blockade of arrhythmias, and therefore is going to regulate the heart rate. So those are some of the medications that are going to be useful in the management of patients with heart failure. Now, other than medications, are there any other things that we can do for patients with heart failure? And the answer to that is yes. And sometimes because these patients are going to be predisposed to sudden cardiac death, an implantable cardioverter defibrillator, an ICD, is usually inserted, particularly in patients who have an ejection fraction of less than 35%. They are going to be candidates for an implantable cardioverter defibrillator because they have a high incidence of sudden cardiac death. And the other thing is cardiac resynchronization therapy. Okay, so what is that? Now, normally, let me just illustrate that here. When we have a normally sized heart, like for example, like this, whenever the right side beats, the left side beats as well. So they're synchronized. So when an electrical energy goes over here, it also goes over here. Now, in patients with structural abnormalities of the ventricles, so let's say that this is the ventricle now, and it's misshapen because of your hypertrophy or your MI. Sometimes this is contracting and this is not contracting. They're not synchronized. And therefore, this is the one that causes the heart failure. And thus, part of the therapeutic intervention is to do a cardiac resynchronization therapy. What we do is we connect a pacemaker over here and a pacemaker over there, so that if this is activated, this is also going to be activated at the same time. So they will beat now at the same time. That's what's called synchronization. Okay? So synchronization therapy with ventricular pacing is indicated with patients with an ejection fraction, usually that is going to be less than 30%. And then, of course, you could also have your left ventricular assist device or your LVAD, and heart transplantation being the last option that's going to be available to patients with terminal heart failure. Okay, so the answer is option B, the BNP or the B-type natriuretic peptide. This is the biomarker that's released by the ventricles when they are very distended. So remember that if it's less than 100, there's no failure, but 100 and above indicates that there's going to be the presence of heart failure. And thus, in this 820, this is going to be a moderate to severe heart failure. All right, so A, B, D, and E are all agents or medications that are going to be prescribed to patients with heart failure. Great. Okay, so let's take a look at the nursing implications. What are some of the interventions as far as nurses is concerned in patients with heart failure? So the first thing is, of course, the importance of intake and output. Because of the fact that there might be fluid retention that is going to be present in heart failure, it is important to measure the intake and output as well as to weigh the patient daily at the same time on the same scale. That is usually done in the morning after the patient voids or urinates, right? And the important thing to remember here is that any time you have an accumulation or a gain weight, I should say, of 2 to 3 pounds, this is going to be something that is going to be a problem or signals a problem, or a 5-pound gain in a week. This is an indication that there is trouble. So this is going to be an important thing to remember. 2 to 3 pounds in a day or 5 pounds in a week. This must be reported to the provider in order to prevent further deterioration of the heart failure. Now, as far as physical examination is concerned, we all know some of the findings that we need to look for to tell us that there is heart failure. Jugular neck vein distension is going to be important. Auscultating for lung sounds to detect an increase or even the presence of pulmonary crackles. And then, of course, heart sounds, because your gallop rhythms are going to be a manifestation that there is an increasing heart rate, in particular S3 and S4 gallops. And then, of course, we always want to make sure that we examine the patients for evidence of fluid overload. So what are some of the evidence of fluid overload? Well, we already talked about the jugular neck vein distension, lung sounds. We could also are going to weigh the patient, would be also other interventions that you could do in order to assess for fluid overload. All right, what you need to think of now is whenever we have an increase in sympathetic stimulation, this is going to be an effort by the body to compensate. And therefore, what happens is that you're going to have tachycardia, you will have vasoconstriction, you could have dysrhythmias. All these are going to be manifestations of a significantly increase in the workload of the heart. So A, B, and C are the correct responses. Letter D should be the opposite, should be tachycardia. And letter E should be the opposite. There would be a decrease in cardiac contractility because of the fact that this is going to result in ischemia. The increase in heart rate and vasoconstriction will result in ischemia of the myocardium and therefore will decrease contractility. All right, so that's the content of our heart failure. Now, let's go to the case study that we're going to have and to apply the principles or the knowledge that we have as far as heart failure is concerned. Okay, before we go to the case study, I'd like to see if you have any questions so far. This is a great opportunity for you to raise them and for me to be able to answer them. All right, if you don't have any questions, let's go ahead and do a unfolding case study. So the nurse cares for a 68-year-old male client who presents for a routine clinic appointment. So I'm going to magnify this so that you're going to read it. Day 1, a 68-year-old male client presents for a routine clinic appointment, reports tiring easily when out shopping for walks. He has been staying home, reading and watching television. Reports difficulty sleeping, awakens with shortness of breath in the middle of the night. Reports 8-pound weight over the past 2 weeks since the last appointment. He states normal appetite. He denies chest pain and back pain. States he is anxious about his condition. No known allergies, current medications, enalapril, 20 milligrams twice a day, hydrochlorothiazide, 25 milligrams twice a day PO, digoxin, 0.125 milligrams once a day PO. Your assessment, the patient is alert and oriented, appears slightly anxious, heart rate regular at 102, and 4+ pitting pedal and pretibial edema. The respiratory rate is unlabored, crackles in the bases bilaterally. Abdomen is soft, non-tender, bowel sounds are active, skin warm and dry and intact, frequent urination, small amounts of clear yellow urine. Okay, so the vital signs at 10 a.m. are 98.6 temperature, pulse 102, respirations 22, blood pressure 170/100, pulse oximeter 93%, and a 215-pound weight or 97.7 pounds. All right, so the question that we're being asked now is, which four findings are most concerning? So remember, they're only asking for 4 findings that are the most concerning. Okay, so when you're answering this question, you're now trying to see, all right, what could be happening to this patient? So you might be thinking, because of the weight gain and so on, the findings that are mentioned here, it leads to possibly that this patient has heart failure. All right, so what findings would be consistent with heart failure. And so the 4+ pitting edema and pretibial edema is concerning. This is because of the fact that this is a sign of a worsening heart failure. Definitely crackles in bilateral lung bases. Now, frequent urination may be, and the appetite, it says that the appetite is, what did we say about the appetite? Normal appetite. So this does not have to be a finding that is going to be concerning. But awakening at night with shortness of breath, is this something that is going to be a manifestation of worsening heart failure? And it certainly does. And the weight gain is going to be also a manifestation of an increasing in heart failure. So this one, the heart rate of 102 is not going to be significantly elevated, and therefore this is not very concerning. And so the thing over here is that the most important or the most concerning findings are going to be B, C, F, and G. Okay? And I think most of you got that correctly. So that would be the way in which we would answer that. Okay. So let's now go to the second frame or the second question. It's the same note at 10 o'clock. And now the question is asking you which two problems is the client most at risk for developing? Which two problems is the client most at risk for developing? And I want you to take a look again over here. Reports 8-pound weight gain, normal appetite, and the medications are enalapril, your ACE inhibitor, hydrochlorothiazide, this is going to be a diuretic, your digoxin, and of course, the signs and symptoms that we have seen earlier. Okay, so we're now being asked to determine which one or which two problems is the patient most at risk for. Okay, let's examine this. What two problems is the client most at risk for? And so if I'm answering this on NCLEX, I will have tentative answers, first of all, okay? So tentative means to say that you are going to consider them, but reconsider them again later. So electrolyte imbalance. Why would there be an electrolyte imbalance? Well, this is a possible one because number one, he is on enalapril. Enalapril is an ACE inhibitor. And we said that ACE inhibitors can cause the hyperkalemia. But he's also have fluid volume overload. Fluid volume overload because of the weight gain. And thus, if there is going to be weight gain, there could be hemodilution. So again, over here, we said because of the ACE and because of hemodilution. Anemia. Why would there be anemia? There's no relationship over here, so let's go ahead and remove this. Well, the patient is fluid overloaded as evidenced by the weight gain, so there's no dehydration. While this is a possibility that there could be a myocardial infarction as a result of this stress, fluid overload obviously is going to be number one because of the manifestation of an increase in heart rate. I mean, in weight, I'm sorry. Diabetes mellitus, there's no relationship. Hyperkalemia is already an electrolyte problem. So that is already in there. So probably the general term electrolyte imbalance will be much better to do that. And then thrombophlebitis, again, there's no relationship. So based on this, I would say that letter A and letter E are the most likely choices. So the client has worsening heart failure. He is at risk for fluid volume overload, as well as electrolyte imbalances from hemodilution in particular, but it could also be as a result of the use of enalapril. Okay? He is also taking hydrochlorothiazide, and he could also become hypokalemic as a result of that, by the way. So if he's not including enough potassium or not taking his enalapril, then it's going to be at risk for hypokalemia. Okay, so A and E are the best responses. Let's move on. So it's still the same findings, but now you're giving a laboratory report. So let's take a look at the lab report. Our cholesterol is 248. That's high because our goal is 200, right? Your BUN is 10, it's normal. Your creatinine is 1.5, slightly elevated. That's okay. Hematocrit is 34. This is a male. It's decreased, and maybe because of the hemodilution. Hemoglobin 13.5, potassium of 2.8. This is low, and the sodium and the chloride are basically normal. All right, so which should be addressed by the nurse first? Which abnormality is going to have to be addressed first? Oops. This is which abnormal finding? I don't seem to have, I lost the question on that one. Oh, there it is. I'm sorry about that. Here it is now. Okay, so it's likely, therefore, that the most important thing is going to be the serum potassium level of 2.8. It's dangerously low, and therefore it is going to, the patient is also on digitalis, so which means to say that the patient can actually be more at risk for the development of digitalis toxicity. So this is going to be the best answer. Okay. Okay, so what now should the nurse include in the teaching plan for this patient? Select all that apply. Okay, let's take a look at the answers over here. What should the nurse include in the teaching plan for this patient? Select all that apply. Okay, weighing themselves every day at the same time in the same clothes and the same scale is going to be an appropriate intervention for patients with heart failure. So we can choose that. Increase intake of oral fluids to stay hydrated. Well, if they're already overhydrated, this would not be a correct intervention. And so we can eliminate that one. Limit sodium in the diet to no more than 2 grams per day. This is a low salt diet, and therefore this is going to be correct as well. Now, reporting weight gains is very important, but the parameter here is faulty because a gait of 1 pound is not significant, but 2 to 3 pounds would be, and a 5-pound weight in 1 week is going to be significant as well. So in as much as weight gain is important parameter, they must report it if they have significant weight gains. But this one is not significant. We still encourage them to be active and also to maintain their activities of daily living as well as far as they can tolerate it. And then, of course, making sure that they take the prescribed medication every day, even if they're feeling better. Now, letter G, eat foods that are high in potassium. The patient is on hydrochlorothiazide, if you remember, which is a potassium depleting diuretic, and therefore, this is a possibility. Now, he is also on enalapril, I believe. There you go, enalapril, which could increase his potassium. So we need to make sure that we watch that diet as far as supplementation with potassium. So this might be something that I would question. Okay. Maybe switch to potassium sparing diuretic. Well, the patient is already on enalapril, so you would increase the potassium levels, Patrick. So that's the problem. Okay. All right. So now we have an entry at 10:30 a.m. So this is the entry at 10:30 a.m. The order is to discontinue digoxin and begin sacubitril valsartan daily along with nutrition consult. Begin low sodium diet and fluid restriction to 15 mLs per 24 hours. Instructed to weigh himself daily and record and return to the clinic in 3 weeks for follow-up. So remember that this is the current one. Discontinue digoxin, begin valsartan sacubitril, along with a dietary consult. Okay, so let's take a look at the next question. The next question is, which of the following actions should the nurse take in response to the change in the medical orders? Select all that apply. Okay, so let's take a look at this particular question over here. Which of the following actions should the nurse take in response to the change in the medical orders? Select all that apply. Okay. Question the medication order. What is the new medication order? It was for sacubitril and valsartan. Well, you remember, let me just go back to here. The patient is already on enalapril. This is a ACE inhibitor, right? And the other one is the new order is to give valsartan. That's an angiotensin receptor blocker in combination with that other drug. So that means to say that the patient is already on enalapril, and then you're going to give this drug. The order obviously has to be questioned because the client is already taking enalapril. All right, so letter A is certainly going to be a correct response. Educate the patient about stopping digoxin. Okay, so what is the problem about stopping the digoxin? Well, because the order right over here says discontinue digoxin, it is obvious that we have to tell the patient to stop taking the digoxin. So that would be a correct response. Educate the client about stopping digoxin. How about instruct the client to start the new medication today? Well, the patient already took their enalapril, so which means to say that the medication should not be started today, right? So this is going to be an incorrect response. Tell the client to take an additional dose of diuretic today. There's no such order. Request that the provider order a potassium supplement. Well, remember that the potassium was 2.8, I believe, right? Right here. So yes, we need to point out to the doctor that he needs to address this hypokalemia. And so therefore, this would be a correct response. There was an order for the patient to have a dietary consult, and therefore we're going to do this. And lastly, determine if the client owns a scale. Now, this is something that we always have to make sure when we're teaching And we're saying you need to weigh yourself daily on the same scale and at the same time after you had peed or urinated in the morning. But one of the things that we fail to always ask is, do you have a scale? So this, I think, is also important. Letter G is going to be important. So these are the proposed correct answers to this, or correct options to this particular frame. Okay, so let's move on. And the thing that is going to be new is right over here on day 14. The client called the clinic to report nagging cough, a pink tinged sputum, and difficulty catching his breath. States he is sleeping in a recliner because he can't breathe when he is laying down in bed. He notes that his wife checked the pulse and it is 90. Reports lack of appetite, thirst, and getting up twice per night to urinate. States he is worried about his health. Advise client that worsening symptoms need immediate attention. Spoke with client's wife who agreed to take him to the emergency room. Okay, so that is the present time on day 14. So we're now going to answer the question that is posed based on that. So you're now going to indicate if the client's status has improved, has worsened, or is unchanged from his condition at the clinic visit 2 weeks prior. So let me just... Okay, so let's see over here. You remember, let me just go back. Unfortunately, I can't have it both. So let's review what was the progress notes on day 14, okay? Client called the clinic to report a nagging cough, pink tinged sputum, and difficulty catching his breath. States he's sleeping in a recliner because he can't breathe when he's laying down in bed. Notes that wife checked the pulse and it's 90. Reports lack of appetite, thirst, and getting up twice per night to urinate. States he is worried about his health. Advised the client that worsening symptoms need immediate attention. Spoke with client's wife who agreed to take him to the emergency room. Okay, so let's go now to this one. Is sleeping in the recliner an indication that the patient is improving, is worsening, or is unchanged? And the correct response here is that this is an obvious manifestation that the condition is worsening. So nagging cough is also the same thing, as well as a pink tinge sputum and difficulty catching the breath. All these are indications that the patient's heart failure requires immediate intervention. All right, how about the lack of appetite is also going to be a indication that this is worsening, and getting up at night to urinate. All these are going to be manifestations of a worsening condition. However, the pulse, if you recall, the pulse rate is 90 right over here. And therefore, that is not significantly changed, right? And so this is unchanged, and or even improved, I should say, because it was 100 something before, I believe. It was 102 before, and now it's 90. So that's an improvement. And the thirst, there's no indication or there's no statement relating to thirst, and so this would be unchanged. Okay, so compare how you answered this, but that's exactly how we would go about in answering a case study question on NCLEX. Okay, so remember the pointers are, if there is select all that apply, be very careful that you do not over-select. It would be much better for you to under-select in comparison to over-selecting. Okay, so ladies and gentlemen, that is my presentation for today. And tomorrow we'll do another cardiac situation. And we're going to do this by system. Okay, so thank you for your participation today. And I look forward to having you again tomorrow. The recording of this class will be made available, and I will send you an email to the link that is going to have that recording. All right. So thank you so much. I look forward to seeing you again tomorrow, the same time and same station. If you have any questions, please stay on the line and I'll be very glad to answer them for you.